This lesson is about quality management. The objectives of the lesson are to examine what are the different types of quality management and to demonstrate quality management within improvement projects. Here's the definition of quality again. It originates from the Latin word of what sort, and it's a standard of something as measured against other things of a similar kind, or the degree of excellence of something. Informal is good quality, but it's really hard to specify. So sometimes it's individual judgment of quality, which depends on different aspects based on your experience, education, and the environment. In other words, quality is hard to define. Here's the Agency for Healthcare Research and Quality definition of quality. It's the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Here's a depiction of the balance of quality between what the requirements and standards are and the performance of those conducting the care to the requirement and standard. So in other words, it's the extent to which a product, which is a good or service, meets the existing requirements or standards. So who is interested in quality? The patient is, because they want satisfactory quality of care, which is product or services. The employee wants quality because they get work-life satisfaction, and that can lead to additional career opportunities. The C-suite and managers want quality because it maximizes the value of what's being provided. And accreditation bodies are interested in quality because of awards, certification, accreditation, recognition, and many other things. And in general, society is interested in quality because they want to see responsible and sustainable behaviors in healthcare. So quality has evolved and changed over time. Back in the 50s and 60s, we called it quality control. Then in the 70s, it changed to quality assurance. And in the 80s and 90s, it was called quality management. And then in the 2000s, we called it TQM, total quality management. So quality control was simply finding mistakes and errors. It was an external assessment and control of those doing the assessing. In other words, people were inspecting what occurred in the past. However, this created a high level or culture of mistrust. And then quality assurance was conducted in an instance to avoid mistakes, and there was personal responsibility and ownership over mistakes. Again, it was looking into the past and planning a little bit for the future from the past. But it also created a culture of mistrust. When it evolved to quality management, it became a systematic fulfillment of patient requirements. It evolved to total quality management because there was a desire for participation of all members within a healthcare organization to have input into the quality. So what are the different dimensions of quality? There are 8. Technical competence, access to service, effectiveness, efficiency, amenities, interpersonal relations, continuity, and safety. So this explains each of them. Effectiveness relates to providing care processes and achieving outcomes as supported by scientific evidence, where efficiency relates to maximizing the quality of a comparable unit of healthcare delivered or units of health benefits achieved for a given unit of healthcare resources used. Equity relates to providing healthcare of equal quality to those who may differ in personal characteristics, other than their clinical condition or preferences for care. Patient-centered relates to meeting patients' needs and preferences and providing education and support. And safety relates to actual or potential bodily harm. Timeliness relates to obtaining needed care while minimizing delays. So these are all the healthcare domains of quality. So how do we actually do it? What are our approaches to quality management? So in quality control in healthcare organization, it refers to activities that evaluate, monitor, or regulate services rendered to the consumers or patients. So in other words, we observe the process, we identify variable characteristics, and we track the variables through statistical methods. There's also a quality control process. This could be monitoring and evaluating performance. It usually includes the following steps. You establish the control criteria. You identify the information relevant to the criteria and determine ways to collect the information. You collect and analyze the information, and then you compare the collected information with the established criteria. And then, most importantly, you make a judgment about the quality. You provide information and, if necessary, take corrective action regarding finding the appropriate quality level desired. And finally, you determine if there is need for additional re-evaluation. So what is quality assurance? It's all of the activities that make it possible to define the standards, to measure and improve the performance of services and health providers so that care is as effective as possible. It's defined as the process for objectively and systematically monitoring and evaluating the quality and appropriateness of patient care, for pursuing opportunities to improve patient care, for resolving identified problems. So the focus of quality assurance is the discovery and correction of errors. These activities are carried out by quality assurance personnel or department personnel. So within quality assurance, you define the quality, measure it, and improve. Defining the quality means you identify the standards and norms or guidelines. One cannot measure what is not been defined, so you need to define it to start. And then you need to measure it. It's the variation in the standard what's important. One cannot improve what one has not measured. And then improving the quality is simply complying with the norms, standards, or guidelines. So total quality management is an approach that's been around for nearly 20 years now. It's a way to continuously improve performance at every level of the operation in every functional area of the organization using all available human and capital resources. It aims to reduce waste and cost of poor quality. The main elements of TQM are three things: the customer, whose needs are paramount to the determination of quality. In healthcare, we know that's the patient. The teamwork, the team working together as a means of achieving the quality. And the scientific approach to decision making based on data collection and analysis. These three elements of TQM must be included in every quality management and quality improvement project. So what is continuous quality improvement? This is a common term used. It's called CQI. Basically, it's a cyclic process. It includes identifying an area where there's an opportunity for improvement, then outlining the sequence of activities that should occur in order to solve the problem, and then implementing them. Once the cycle is completed, it has to be determined whether the problem has been solved or not. If the problem continues, the cycle should be repeated. CQI is commonly used in healthcare. Based on the Japanese philosophy of Kaizen, CQI and Kaizen means good change or change for the better. It in essence means never-ending efforts for improvement, continuous learning from mistakes, and organizational learning, involving everyone in the organization, all hierarchy levels from the CEO to the lowest level workers. It's process-oriented rather than outcome-oriented. from small steps to big results. So as you can see here, this is a wonderful depiction of what actually could occur at a 0% rate to the 100% rate, which is the desired standard procedure or protocol. It's actually the area in between is the opportunity for improvement. It's the difference between the actual, which on this picture is 0%, and the desired state, which is 100%. So standards of performance are defined for measurement using indicators. So what are the effects of continuous quality improvement? It can detect resources and synergies, optimize workflows, processes and symptoms, improve the product and services, and patient satisfaction. And it can optimize the use of resources. It supports skills, creativity, and commitment of the employees, and it improves teamwork and corporate culture. But it can also increase the pressure to perform for employees. Most of you are familiar with the Plan, Do, Study Act or Plan, Do, Check Act from Edward Deming. It's basically the depiction of CQI or continuous quality improvement. It's commonly used in most healthcare organizations, and many of our graduate students in KCON use this model when implementing their scholarly projects. It's a quality management system. So how do you use the PDSA cycle? You use the Plan, Do, Study, Act cycle to conduct small-scale tests of real change in real settings. You plan a change. You do a small test, you study its effects, and you act on what you learn. The team uses and links small PDSA cycles until they're ready for broad implementation. Here's a depiction of what the PDSA cycle can look like. It's also very common for PDSA cycles to be done in single tests or in multiple tests to solve a single problem. It's not unusual because you learn as you go along. You have to tweak your plan and retry it all over again to get the effect that you want of your improvement. There is an impact and implementation phase. You have to measure the impact of the changes or the interventions. You have to record the results, revise the interventions, and monitor the impact again. This is something that sometimes is challenging for graduate students to understand. If you don't define it and measure it, you do not know if it's improved, which is the basis of quality improvement. So measuring the impact of the change or the intervention is key to quality improvement. You also need to think about sustaining an improvement. Once an intervention's been introduced and the intervention has improved what you desire, it needs to be sustained. This may involve standardization of existing systems or processes, documentation of policies, procedures, protocol, or guidelines, or measurement and review of interventions to ensure that change becomes part of standard practice. And there may be a need for ongoing training and education of staff. So as you can see here, to sustain a quality improvement, you might need to have standardization, documentation, ongoing measurement, and training. These are things to think about when you're conducting a quality improvement project, to design sustainability into your project to assure that the improvement continues after the project's completed. One way to think about identifying problems is a root cause analysis. These are commonly used by multidisciplinary teams. A root cause analysis effort is directed towards finding out what happened and establishing the contributing factors of root causes. This is what a flow chart can look like with a root cause analysis. There's something amiss, like a visit to a general practitioner. There's investigations, referral to a surgeon, referral to a hospital, hospital admission, or return to life. If they go into hospital admission, as you can see, the flow chart becomes even more complex before they're back home again. They have to go to the admission office, perioperative clinic. They're admitted to the hospital, pre-op ward, the OR, post-op. Then they're on the surgical ward. They might have allied health, pain team, discharge planner, surgical team. And then afterwards, they might be discharged to visiting nurses, and eventually they're home. As you can see, flow charts of processes of care are extremely complex, but they're very important to do because they help you identify where improvements can be made in care. And there's also cause and effect diagrams. These are fishbones. These help you identify the factors that may be contributing to the cause of a problem that is not the effect you desire. This example shows prolonged length of stay and hospitalizations. Some of the causes are social issues, staff attitudes, complications, procedures not being followed, patients' perceptions are poor, and poor discharge support. So all 6 of those items can lead to prolonged length of stay. And if you do a cause and effect diagram, it helps you identify the sub-items in each of the fishbones which may be able to become part of a quality improvement project to improve length of stay. And just so you know, when you're doing quality management, rowing is never enough. It's hard work that needs to be done over and over again. It needs to have dedication and commitment and persistence. So think about the assignment this week. Think about the following elements. Complete the worksheet as assigned, and remember QI is an iterative process, and your worksheet may change as you learn new or additional information or find new evidence. So in regard to quality management, the first strategies are to develop the quality monitoring tools with the appropriate language, protocols, algorithms, standards, and measures of process, patient outcomes, and implementation outcomes that are specific to the innovation being implemented. Use advisory boards and work groups to involve multiple kinds of stakeholders, knowledge users, to oversee implementation efforts and make recommendations. Think about auditing data and providing feedback of performance over a specified time period, and give it to innovation providers and administrators to support behavior change of clinicians. You may include recommendations that stem from a variety of sources, including medical records, computerized databases, observation, or feedback from patients. A performance evaluation could also be considered as audit and feedback if it included specific information on clinical performance. Quality management strategies 2. Develop and organize a quality monitoring system and procedures to monitor processes and/or outcomes for quality assurance and improvement. This might involve peer reviews, collecting data from innovation recipients, practitioners and supervisors, and/or using administrative and electronic record data. Also includes the design of disease-specific clinical registries, or clinical information and tools, or graphical representations of real-time report cards, or comparisons with benchmarks, or something else. They're available to care team members. These systems may inform audit and feedback strategies. And also reminders. Develop reminder systems designed to prompt innovation for providers to recall information or use the innovation. The reminder could be recipient or encounter specific, provided verbally, on paper, or via email on a computer screen. Computer-aided decision is support, and drug dosages are included in this strategy. And then quality management strategies 3. Obtain and use feedback about the implementation effort. You could include complaint forms or methods to funnel feedback for your review. You should provide supervision to those providing the innovation and train their supervisors. Use data warehousing techniques to integrate clinical records across facilities and organizations to facilitate implementation across symptoms. Intervene with recipients of the innovation to enhance uptake and adherence to the innovation. This includes reminders and financial incentives to attend appointments or use the innovation. Quality Management Strategies 4. Purposefully re-examine the implementation effort and obtain stakeholder commitment to use monitoring to adjust practice and strategies, to continuously improve the implementation effort and delivery of the innovation. Conduct cyclic small tests of change before taking changes systems-wide to gather insight on how to do better. Repeat and refinement within each cycle. Consider PDSA from Deming's quality management work, or Six Sigma's define, measure, analyze, improve, control sequence. In other words, be systematic. Centralized technical assistance focused on implementation issues. This could be the designation of a lead technical assistance organization who could also be responsible for training and who could develop other mechanisms like call-in lines or websites in order to share information on how to best implement the innovation. Quality Management Strategies 5. Organize a clinician implementation team meeting to develop and support teams of people who are implementing the innovation and give them protected time to reflect on the implementation effort, share lessons learned, and support one another's learning. Use data experts. Involve, hire, and/or consult experts in data management to shape use of the considerable data that implementation efforts can generate. Capture and share local knowledge from implementation sites on how implementers and clinicians made something work in their setting, and then share it with other sites. See centralized technical assistance and learning collaboratives as an example. Use an improvement or implementation advisor, such as a consultation with outside experts at a university-affiliated faculty members, or hiring quality improvement experts or implementation professionals to manage the project. So, in quality management, you also have to attend to policy strategies. You have to change accreditation or membership requirements so that they require or encourage use of the innovation. You can work to alter membership organization requirements so that those who want to affiliate with the organization are encouraged or required to use the innovation. This is one approach. You can create or change credentialing and/or licensing standards that certify providers in the innovation and encourages an existing organization to do so. You can change governmental professional certification or licensure requirements to include delivering the innovation. You can work to alter continuing education requirements to shape professional practice towards the innovation. You can also change liability laws. You can participate in liability reform efforts that make innovation providers more willing to deliver the innovation. All of these are very important policy strategies. So think about the assignment this week and complete your worksheet accordingly. Thank you.